For this next session of the Future of the American Child Journalism Training, we're going to be focusing on the social determinants of health. So many of the conversations that we've had during the program about education, mental health, child welfare reform, a lot of it centers on whether or not the social determinants of health are being factored in to whatever innovation or reform that we're talking about. And when it comes to children today, we can't deny the extreme pressures and considerations that families and children have to take into consideration. So it's our pleasure today to welcome Dr. Roopa Thakur. She's a pediatrician, but also a researcher who has spent the past decade, several decades, focusing on this very issue, the social determinants of health and how they are factored into the delivery of health care and access to health care for children. So we welcome you. Dr. Thakur is with the Cleveland Clinic, I should say. So please welcome to our program this morning.
Thank you for having me. My little disclaimer here is that I do a lot of virtual interviews. This is one of my very few in person. So I get a little nervous. If I talk too fast or too soft, let me know and I can try to modulate a little bit. But thank you so much for having me here today. I'm a primary care pediatrician. I see patients, for those of you who might be local, might know the area a little bit, at our Independence as well as East Cleveland locations. So very different patient populations. I serve as medical director for youth strategies for community health and partnerships, as well as medical director of our school-based health program. So I'm here to talk to you a little bit about social determinants of health affecting children. So if you'll bear with me, I'm just going to go over some of the basics. I know a lot of these concepts might be familiar already, but just wanted to cover some basics before we go into specific issues. So again, many of you might already know about primary prevention, but I just wanted to share a story that kind of made the concepts of why we're looking at primary prevention, a story that helped those concepts really click for me. So let's imagine that we're having a lovely little picnic next to a fast-flowing river, and all of a sudden we see a man crying out for help, struggling in the water as he's kind of being swept downstream. We're able to pull him out, but wouldn't you know it, there's a second person that comes drifting down. We continue to rescue dozens of people as they come being swept down the river. We save them each one by one. We refine our process until we're actually pretty good at finding and pulling these people out of the water. And then one of us starts walking away. And we call after her. We're like, where are you going? What are you doing? We need you here. We can't save all these people if you leave. And she answers, I'm going upstream to stop whoever's pushing these kids or pushing these people into the water to begin with. So this is the idea of primary prevention, really looking at the source of an unfavorable outcome and trying to address that root cause. In contrast, secondary prevention is a lot of what we do as healthcare professionals. We look for that unfavorable outcome by screening, and then we try our best to address it after we found it. Tertiary prevention refers to interventions that aim to address complications or sequelae that have already happened to that person. So in the case of our example, secondary prevention would be our process we developed to find and pull those people out of the water. Tertiary prevention might be warming and drying the patient to prevent hypothermia that happens from having been in the water. So just to kind of give you an idea of what we're thinking about. You're not going? There we go. So why am I starting with that story? We know that health doesn't happen within our hospital walls, within Cleveland Clinic walls or any other clinic. It happens where people live, eat, work, and play. So this is why we focus on social determinants of health, recognizing that the root causes of our population's health are shaped by the politics, economics, and structure of our community. So to put this in numbers, only 20% of a population's health is determined by the clinical care that it receives. Policies and programs that influence the physical environment and socioeconomic factors can have more than double that impact. And the effect of the choices that a person makes based on the resources that they have access to also has more impact than our clinical care. So if we're even to attempt primary prevention for many of the unfavorable outcomes that we see in our population, we need to understand what those social determinants of health are, and we need to consider systemic changes that could mitigate those factors. So why is this important? We know that socio-behavioral factors associated with poverty and racism can cause trauma with lifelong effects. So when this happens in childhood, we call these ACEs, or adverse childhood events. And these factors include some pretty obvious things, like witnessing violence, growing up in a home with mental health or substance use problems that are untreated, or being separated from family members due to incarceration. Less obvious ACEs include living in under-resourced or racially segregated neighborhoods, frequently moving, and food insecurity. These factors cause toxic stress that can negatively affect a child's brain development, immune system, and stress response system. These changes can affect a child's attention, decision-making, and learning. They may have difficulty forming healthy and stable relationships as adolescents or as adults. They may also have unstable work histories as adults, struggling with finances, jobs, and depression. The CDC also states that an increased ACEs count is associated with increased risks of injury, sexually transmitted infections, maternal and child health problems, including teen pregnancy, pregnancy complications, and fetal death, involvement in sex trafficking, and a wide range of chronic diseases and leading causes of death such as cancer, diabetes, heart disease, and suicide. By preventing ACEs, up to 1.9 million heart disease cases and 21 million depression cases might be avoided, a reduction of up to 44%. The economic and social costs to families, communities, and society totals hundreds of billions of dollars each year across the globe. And the CDC estimates that a 10% reduction in ACEs in North America could equate to an annual savings of $56 billion. So how do we do this? How do we combat ACEs? By providing safe, stable environments for children and families in our community. And that's easier said than done. So we'll think a little bit about what interventions we might be able to think about from a healthcare perspective, but also just in terms of societal programming as well as we move forward here. So as these concepts have kind of taken hold of our collective conscience, the notion of anchor institutions has arisen. So anchor institutions are place-based, mission-driven entities that leverage their economic power as well as human and intellectual resources to improve the long-term welfare of the communities. So I think the term actually first appeared in the literature in the early 2000s, with data showing that universities, hospitals, and other large nonprofits, have the ability to transform the neighborhoods, cities, and regions around them. And they do this by hiring, buying, and investing locally. So part of this is committing to take steps to eliminate structural racism and increase communities' trust in those organizations as a partner in their health and their well-being. Some of this is done by organizing public health initiatives to address pervasive issues like infant and maternal health, social and emotional wellness, and healthcare access across the lifespan. So I'll just tell you very briefly, Cleveland Clinic's community health strategy kind of follows the same concept, this kind of shared mission. So we use the biennial community health needs assessment to screen within Cleveland Clinic's footprint to identify which communities have the greatest needs and what those specific needs are. The community health needs assessment determines the who, where, and what of our health strategy. And that strategy is in place typically for 2 years at a time until we get the next needs assessment. So then we think about the how. How can we leverage partnerships with community agencies or businesses to close those specific gaps for the populations that we've identified? And what metrics will we use to ensure that those initiatives or programs are successful? So in general, we talk about healing, hiring, and investing. We aim to heal our most vulnerable populations, addressing the root causes of suboptimal health outcomes by screening for and connecting individuals to any needed social or healthcare resources. So we incorporate patient navigators, community health workers into our practices to try to help make those connections for families, and I'll talk a little bit more about that in a moment. Or we think about integrating healthcare into the community. So school-based health and one of our locations here, Langston Hughes, are great examples of that, and I'll show you those in a minute as well. We aim to hire locally by operationalizing workforce development and hire local efforts. So we partner with school districts, community colleges, and other key stakeholders to implement strategic efforts to hire from within the local community. And so I'll show you a little bit of that in a moment as well. And then investing refers to operationalizing or demonstrating our investment in the community by buying locally. So we invest in businesses that are in our local neighborhoods, improving the economic standing of the community. And so when we think about Hire Invest specifically, those are really our anchor strategies. What are we doing as an anchor institution to give back to the community around us? And our levers for change, I should say, are partnerships, education, strategic programming, advocacy, and funding that you see at the bottom there. So I'm going to give you a specific example just to illustrate a little bit about what this looks like. So Fairfax is the neighborhood that is immediately adjacent and surrounding Cleveland Clinic's main campus down the street here, downtown. But as I talk about this specific neighborhood, just keep in mind that we are thinking and acting similarly in Akron and Lorain and Warrensville Heights and other communities that popped up as high need on our needs assessment. So based on our community health needs assessment, we know that Fairfax experiences high rates of infant mortality and chronic disease. The population overall is declining. At the same time, we see that lots are going vacant, rates of crime and unemployment are rising. Our neighbors are suffering economically, socially, and in terms of healthcare access, even though we are literally right next door, they still don't have access to us. And so for this reason, Fairfax and communities like it are the primary focus of our health strategy. So one of our most well-known successes in the Fairfax community is the Langston Hughes Community Center. This is where residents of the community can access primary care, navigation services, a teaching kitchen, a prescription gym, and other resources to address their needs across the lifespan. During the pandemic, this site also served as an essential COVID vaccination site for the community. And I mentioned earlier that I lead our school-based health program, so I'm going to call out here too that our school-based health team started service to Bolton Elementary School, which is the elementary school in this neighborhood. Based on the school's identified needs, our program's mental health provider, Dr. Benez, has piloted a series of sessions focusing on social and emotional well-being in the elementary and middle school ages. So really teaching them mindfulness, how to recognize when they're anxious, how to recognize when their mood is drifting, and how to identify trusted adults, express their emotions, those types of things at an early age. Our Cleveland Clinic Lerner College of Medicine medical students have developed a curriculum around hygiene and healthy habits in response to requests from the school as well. So when the school later then identified an increased number of students with mental health concerns like anxiety or depression, Dr. Benez worked with the team at Langston Hughes to transition some of his clinical time there so that he could see children in the community and give them access to mental health services at a site close to home by a provider that they already know and trust. So when we look at this neighborhood as a whole, we're thinking about how to re-envision all those empty lots I mentioned a moment ago, providing green spaces for all ages to play and exercise, recharge, and come together as a community. Additional invest strategies include partnerships with local businesses I mentioned a moment ago. And we partner with them to supply or provide a lot of the necessary services that we need to keep our hospital functions going. So one example is our partnership with Evergreen Cooperative Laundry. For those who might be unfamiliar, the Evergreen Cooperatives of Cleveland allow local residents to earn an ownership stake as they build their own businesses, and they partner with University Circle anchor institutions to create jobs that drive economic stability in neighboring communities. So Evergreen Cooperative Laundry is one of the few commercial laundry operators headquartered in the city of Cleveland, and they offer cost-effective green options for clients in the hotel, hospital, and nursing home industries. So we are, of course, very proud to do business with them and help local community residents build their business. And I know that youth education to workforce development is on this slide, so keep that in the back of your mind. We're going to circle back to that in a few minutes here. So Innovation Square is a strategic investment project that targets and catalyzes real estate development in the Fairfax neighborhood. The project is designed to provide new, improved, and varied housing options to expand residential population and bring new employment and cultural opportunities to the neighborhood. So here we'll see, starting with green space, there's a reinvestment in arts and civic amenities that help fuel community pride. Neighborhoods serving retail will enhance economic stability on Main Street blocks. And recognizing that this area is a food desert, Meijer is partnering with us to open a grocery store offering affordable produce as well as job opportunities for local residents. So just giving you that brief overview of what we're thinking about organizationally as an anchor institution, what are some of our strategies, and now we're going to dive into some of the issues specifically related to children. So I can talk about lead poisoning for days. So I'm gonna try to keep this brief, but I'd love to share some of the work that we've done in Cleveland around lead poisoning prevention as a potential success story, so that when we talk about a few other issues in a moment, it might give us a little bit of a framework to think about those. So we know that Ohio has the third highest percentage of elevated blood lead levels in the country, and that 41% of those children live in Cuyahoga County, which is where we are now. Why is this concerning? We know that lead is a neurotoxic metal that deposits from the blood into every single tissue in the body, and it impairs basic cell functions that are common to all tissue types. So because of this, lifelong consequences of childhood lead exposure can include decreased bone and muscle growth, hearing loss, damage to the nervous system, ADHD, developmental delays, and overall decreased IQ. For those stakeholders that isn't enough and they want to see what the bottom line is, we know that for every $1 spent on lead abatement, there's a minimum of $17 return on investment. And that's pretty conservative. When efforts are targeted in high-risk communities, like the city of Cleveland, the return on investment can reach as high as $221. This not only reflects spending on the sequelae of lead poisoning that I mentioned a moment ago, but it also reflects public spending on resources that an individual with lead poisoning may require across their lifespan. A 2020 study that was done by Case Western University here, looking at lead poisoning in our community and its downstream effects, found that as young children, kids who have been lead exposed are 27% less likely to be on track for kindergarten and to require early intervention services. As teens, they are 25 to 30% more likely to enter the juvenile justice system, and as adults, they're 34% more likely to be incarcerated. By their early 20s, they're 40% more likely to experience housing insecurity, requiring services to address homelessness in addition to other public aid. And so when we kind of think about the overall cost of all of that support, there's definitely a financial incentive for this type of investment on a national or societal level, but ultimately we know that it's just the right thing to do for our community, for our families. So we've made our case for why lead poisoning is bad. Where is all this lead coming from? Where do we focus our efforts now that we've identified an issue? So we know that 80% of Ohio's lead poisoning cases are related to our housing stock. This is because 2/3 of Ohio's housing was built during the lead paint era, which is before 1978. 90% of Cleveland's housing stock was built during the lead paint era. So this is why we focus on primary prevention. When we go back to that story about going upstream, we need to address our contaminated housing stock, our aged housing stock, to eliminate the threat of lead exposure and end lead poisoning in our community permanently. So as healthcare providers, sorry, I keep hitting this, I'm really sorry. As healthcare providers, we have always known, of course, that lead poisoning is bad, it's irreversible, and that it's caused by poor housing conditions. So of course, we continue on quality improvement to increase how many kids we're screening and testing and try to identify those children as early as we can. But ultimately, we're still identifying those kids when it's too late. So one of my colleagues at UH used to say, we're using kids as lead detectors rather than protecting them from lead in the first place. So we had a reactive approach when we needed a proactive approach. And this actually happened back in 2019 with the Lead Safe Cleveland Coalition, helped make that shift. So, there we go. This is the early coalition members. We joined this inclusive public-private partnership with a shared goal of no child with an elevated blood lead level by 2028. So the coalition is comprised of community stakeholders like landlords, parents, pediatricians from all of the healthcare organizations in the area, contractors who do the lead abatement work, child care centers, families impacted by lead poisoning. So there's a clear value placed on community voice here. The work is chaired by community-facing agencies with both influence and expertise in making change happen. So examples there are Cleveland Housing Network, Enterprise Community Partners, United Way, just to name a few. So we joined our voice with those community partners to shape policy that I'm hoping will radically change the landscape of lead screening and poisoning in our children if it's implemented effectively. So this was the Lead Safe Cleveland Ordinance that will require every rental unit built before 1978 to be certified as lead safe by inspection by this year. So it's just going into effect now. The registry has been open and people have been getting their units registered on it, we'll see the effects of this in the coming 2 to 3 years. So for this reason, Cleveland Clinic and a lot of our other healthcare partners in the region have pledged money towards the Lead Safe Cleveland Coalition and the United Way of Greater Cleveland to seed the Lead Safe Home Fund. Cleveland Clinic in particular has pledged $52.5 million. And the vast majority of our contribution to the Lead Safe Home Fund is dedicated to lead safe grants to property owners. So this includes homeowners and landlords to support our community's families through the lead abatement process. In addition, our government relations team has advocated for ARPA funds to be appropriated to lead remediation across the state. This is House Bill 587 for any of you who are interested. And we did this in partnership with the Ohio Lead Free Kids Coalition, which joined folks from all over the state to advocate for that bill. So these are examples of Cleveland Clinic's efforts around primary prevention, addressing the housing problem. We're also continuing to focus on screening and testing, those secondary prevention efforts. So we're doing continuous quality improvement to ensure that kids that are at risk for lead poisoning are being screened and tested according to CDC and Ohio Department of Health guidelines. So some of the work involved in that was really optimizing our electronic medical record system, looking at how we can flag kids who warrant a lead test, but it was never ordered, and how do we educate providers to know when they need to order those tests, and then looking at those kids who had a lead test ordered, but then something dropped off and they never actually got the test completed. And a lot of that just happens from leaving our exam room with the intent to go to the lab. There are a million reasons why that connection never happens. So we're now collaborating with our partners in laboratory medicine to evaluate and adopt capillary testing so that when I have that kid locked in my room, I can prick their finger and get that test done before they even leave the office. So we're hoping that this pilot will be up and running within the next couple of months here. So we also know, though, that kids aren't necessarily walking into our doors to begin with. Especially during the pandemic, our well-child visit rates dropped. We are still not quite back up to 2019 levels. So maybe we need to go to those kids rather than expecting them to come to us. And with this mission in mind, our school-based health program has partnered with Step Forward to conduct lead screenings for children under 3 enrolled in early Head Start child care centers, in addition to the Head Start preschools that we were already doing screenings in. We've also launched a lead monitoring program this year, which is designed to provide wraparound services to families of children with elevated blood lead levels. So this is kind of a tertiary prevention program. But part of this program integrates our primary care social worker team to help families access resources that they might be eligible for, like legal aid if they're renting and having issues with the landlord, public benefits, resources for home inspections, funding for lead remediation, and identifying EPA certified contractors to perform that work. So I wanted to think a little bit about what are our key takeaways from this, like I said, potential success story. We don't have the outcomes yet to say it's a success, but I'm pretty hopeful. So my key takeaway here was the importance of partnerships. We need to leverage the influence, skills, and expertise of our partners to reach at-risk families, as well as to create policy change. So parents, teachers, and residents of the community, these people, of course, carry huge influence as constituents who will be re-electing legislators or public officials. And so if their voices are leveraged, the chances of policy change are, of course, much higher. Community-facing agencies like Cleveland Housing Network, Enterprise Community Partners, the ones I mentioned earlier, these organizations can build the infrastructure needed to organize advocacy, funding, logistical planning, and program evaluation. And then we as healthcare professionals can act as experts in explaining what lead poisoning is, how it harms our children and our community at large. And then property owners who have gone through the abatement process can act as experts, citing the resources that were helpful to them as well as where the system failed them. And when we think about those specific families who have children with lead poisoning and thinking about how to reach them and provide the resources that they need, I feel like our partnerships really hinge upon finding those trusted individuals in the community who can link families to the appropriate resources. So to illustrate this point, not lead poisoning related, but more mental health related, I'll share that Glenville High School, which is also in that Fairfax neighborhood, identified a need for mental health awareness. Students were exhibiting signs of depression and anxiety, but their parents weren't always engaging with mental health services for many reasons. And the most common that were cited were mistrust and stigma. They didn't want their child labeled with a mental health disorder, and they didn't necessarily trust the medical community, especially during the pandemic when they were afraid that we would stick their kid with the COVID vaccine if they came into our doors. So Cleveland Clinic partnered with community mental health providers to offer youth mental health first aid training to trusted members of the community, including faith leaders, teachers, sports team coaches. The idea being that if these people were trained to recognize concerns, they could more effectively communicate to the parent than a health provider that the family may have only seen once per year up until then. They could provide resources, and the chances of connection to the mental health provider might be higher. So this example, I think, just kind of highlights partnerships with trusted members of the community and leveraging their expertise as professionals to do the needed work well. So I could come up with a program to do something similar, but I am not a therapist, and me trying to come up with that program may not have been very effective. So really leveraging the people who are already doing the work and doing it well and being that liaison or connector. So my last thought here is around community health workers. And I don't know if you are familiar with the concept or their role, but the American Public Health Association defines a community health worker as a frontline public health worker who is a trusted member of and has an unusually close understanding of the community served. This trusting relationship enables the worker to serve as a liaison between health or social services and the community to facilitate access to services and improve the quality and cultural competence of service delivery. A community health worker also builds individual and community capacity by increasing health knowledge and self-sufficiency through a range of activities such as outreach, community education, informal counseling, social support, and advocacy. So don't we need more of that? I think about what that type of a role could do for a lot of the families that we serve, and just thinking about how can we leverage the unique position of a community health worker in driving the work that we know we need to do. So with these lessons in mind, let's look at some of the other issues that children in our community face regularly, starting with food insecurity. So it's estimated that in the US, 9 million children are food insecure, meaning that they don't know where or when their next meal will come. In Ohio, 1.3 million people are hungry, and over 380,000 of those are children. This equates to 1 in 7 children in Ohio being hungry, and data from the Greater Cleveland Food Bank cites 1 in 5 are hungry in our region. Just like lead poisoning, Cuyahoga County has the highest rates of food insecurity in the state. That data is from 2017, with 59% of the City of Cleveland residents identified as living in food deserts. So this map kind of shows you what areas are food deserts. When we think about access issues that define food deserts, these include transportation to, distance from, and availability of healthy food. So this figure shows supermarkets in Cuyahoga County. The areas in yellow, orange, and red are neighborhoods that are more than a half a mile from a supermarket and are lower income. So approximately 40% of Cuyahoga County residents live 1 or more miles away from a supermarket in those red and orange neighborhoods. And these are largely composed of minority populations. So as a result, we know that food insecurity, especially in our region, disproportionately affects Black and Latino youth. So what are we trying to do? Leveraging our partnerships, Cleveland Clinic's Food as Medicine team, which is led by my colleague, Dr. Monica Yepes-Rios, and Rosemary Miles. That team is working on all of the initiatives here, plus more. So we are, of course, performing our due diligence with quality improvement efforts to ensure that 100% of children receiving care in our primary care and OB departments completes food insecurity screening at least once per year. We are integrating community health workers to help enroll patients that are identified as food insecure in SNAP and WIC, and trying to connect those patients to both Cleveland Clinic as well as external food assistance options. So that's where we're trying to pull in that role of a community health worker. In collaboration with the Greater Cleveland Food Bank and Children's Hunger Alliance, we are helping to close the funding gap for children to receive nutritious weekend meals, which are typically distributed in backpacks on Friday afternoons at their school. We're also advocating to increase or at least maintain funding for school meal programs at the local, state, and federal levels to ensure that children have access to healthy meals for breakfast, lunch, and sometimes even an afternoon snack. There's also ongoing advocacy around improving the nutritional quality of the meals provided, which is a whole nother issue. We are also exploring partnerships with Meijer and Dave's Grocers to provide food vouchers, and Instacart to provide door delivery to food insecure families living in those areas where they can't easily access a grocer. Cleveland Clinic is also offering nutritional education alongside its food pharmacies, or medically tailored meals is another common name for this, for patients with chronic conditions requiring a specialized diet. So that might include diabetes or chronic kidney disease. At Langston Hughes, that I mentioned earlier, we are building a comprehensive teaching kitchen program, which includes cooking classes, nutritional counseling, meal delivery, an urban garden, and more. They actually started planting a few weeks ago. I was a little nervous about the frost, but it seems like it's been going pretty well. And finally, we're joining our community partners in Case Western Reserve University's Nourishing Power Network. This is another collaborative similar to the Lead Safe Cleveland Coalition, where we can join our voice with other community stakeholders to advocate for our most vulnerable populations. So we'll switch gears a little bit and think about another key topic, which is infant mortality. So infant mortality is defined as the number of deaths in children under 1 year of age per 1,000 live births. And this is considered a key indicator of overall health of a region. So put in plain words, the higher the rates of infant mortality, the less healthy a population is overall. Public data confirms that Cuyahoga County's infant mortality rate has consistently been one of the highest in the nation for decades. Of the 13,204 babies born in Cuyahoga County in 2020, 101 didn't make it to their first birthday. Our infant mortality rate was 3 times the national average in 2015. And just as we've discussed with lead poisoning and food insecurity, we know that children of color are disproportionately affected. In 2018, the mortality rate for Black babies in Cuyahoga County was 15.4, while the mortality rate for white babies was 3.8. In the city of Cleveland, we know that things are even worse. So that was county data. In Cleveland, the mortality rate for Black babies was over 17, while the mortality rate for white babies was 3. So in other words, for every white baby that died before their first birthday, nearly 6 Black babies died. In addition, Black women at every socioeconomic level have higher rates of infant death than white women who have not completed high school. So if we try to think, well, maybe this is an education issue, maybe, a lot of those confounding factors are washed out when you look at the data this way. So again, leveraging partnerships. My colleague, Dr. Tosin Goji, has been working diligently with her team to move the needle on infant and maternal mortality. We have plenty of opportunities to expand clinical services to expecting and new mothers. I'll just focus a little bit on centering parenting and centering pregnancy. So if you're not aware of those, these are shared medical appointments where moms around the same stage in pregnancy meet for their OB appointments. To learn from a medical provider, there's usually a community health worker involved in that as well, and they learn from each other as they progress through their pregnancy. So we are now piloting centering parenting programs to allow those mother-baby dyads to continue their journey together through the first year of life. And it really forms kind of a support network with that community health worker acting as kind of glue for the group and hand-holding through a lot of the issues that they might face in those 2 years of pregnancy and the first year of life. 9 months of pregnancy and first year of life, but 2 years altogether. Other initiatives that we're working on, we organize community baby showers in partnership with local community agencies who help provide safe car seats, strollers, and basic supplies for expecting mothers. Our government relations team has actively advocated for the Save Our Mothers Act, which the goal there is really to enforce continuing education requirements for birthing facility personnel, as well as requiring an initiative to improve birth equity, reduce peripartum racial and ethnic disparities, and address implicit bias in healthcare systems across the state. And again, we have joined our community partners in community collaboratives or coalitions to try to lend our expertise in creating policy and programming changes that can help close the gap for this vulnerable population. So 2 examples are First Year Cleveland, as well as First Term First Birthday, which is focused in Akron. So First Year Cleveland, similar to Lead Safe Cleveland Coalition, was established in December of 2015 by community leaders who were alarmed by the number of babies that were dying in Cuyahoga County. Today, this collaborative effort brings together parents and expectant parents, community leaders, philanthropic organizations, government and business entities, healthcare providers, educational institutions, nonprofits, and the faith-based community. And all of those people help to lead the work of 11 different action teams focused on research, educational programs, community awareness, and really their overall mission is to reduce racial inequities, address extreme prematurity, and eliminate sleep-related deaths. So just kind of giving you an idea of the scope of the work they do with all of the stakeholders that they involve. So I know we just covered a lot, but I wanted to highlight a couple additional programs that might help support all of these initiatives, as well as more. So I'm particularly excited because some of this is the work that I lead. So again, I'll try to keep it brief, but if you have questions about it, I'm happy to answer those. The first is medical legal partnership. So Cleveland Clinic actually was the last in the region to develop a medical legal partnership. So I was excited to be a part of its initiation here. A medical legal partnership is a national evidence-based model integrating the unique expertise of lawyers into our primary care practices. So the idea here is that if there are social determinants of health that we cannot address directly, but that some help navigating the legal system might help address, they can do that. In this model, lawyers and paralegals are embedded in our primary care practices. And based on existing research, we know that MLPs have been found to improve several health outcomes associated with social needs, including reduced frequency of hospital admissions, increased medication adherence, and lower reported levels of stress. In general, the goals of an MLP are to remove legal barriers to health and improve health outcomes by providing on-site free legal services to primarily low-income patients. Hopefully with the streamlined referral process, we're still working on streamlining ours. A second goal is educating multidisciplinary teams of healthcare providers and students to recognize civil legal issues that can interfere with patient health and understand what a patient's legal rights are in common scenarios. So when we think about geriatrics and real estate planning and issues of inheritance and things like that, as well as when we have our medically complex children and we're looking at guardianship and proxy as they get older, thinking through what their rights are in those different situations. And then the third goal is really engaging in collaborative and cross-disciplinary community legal education, outreach, and advocacy on topics that we see in real life are affecting the outcomes of our patients, including racial justice and equity. So our pilot right now is focusing in pediatrics. We look at largely housing insecurity and unhealthy conditions, so that includes lead abatement or remediation. For those patients with developmental delays or who are medically complex, our legal aid partners can help navigate the school systems for IEPs or 504 plans, as well as navigating the legal system for parents pursuing healthcare proxy or guardianship, as I mentioned a moment ago. In addition, legal aid staff can support our practices in advocating for patients and their family with concerns related to food insecurity, income and health coverage, and other public benefits that they may be eligible for. So that's an MLP in a nutshell. Next, I'll talk very briefly about school-based health. I've mentioned a few times already, but this is another national best practice model where we provide all the basic primary care services that you would expect in a pediatrician's office in the community at the child's school. So in my mind, this is population health at its best. So if a patient or family can't come to us, that's fine. We'll come to you. We'll provide the services of a medical home or in conjunction with their medical home with minimal interruption to the child's education and the parent's workday. Our program currently does this with an in-school clinic at the Lakewood High School, which if any of you are interested in touring, I can try to arrange that for you. And then we also have 2 mobile units that serve schools in the inner ring suburbs of Cleveland. And we know that in our inner ring is where resources and access to care are typically limited. It seems that resources are a little bit more concentrated in the city of Cleveland and then those outer suburbs. So we try to keep that in mind as we're negotiating with school districts around services. We provide yearly physicals, immunizations, routine age-appropriate screenings. We can perform assessments for illness or major injuries, chronic condition follow-up, medication checks, ADHD, depression. We can offer some reproductive health services. And then knowing that our school districts are identifying a growing need for mental health access, we have integrated pediatric psychologists and psychiatrists into our school-based health teams. So we're, in addition to those mental health providers, also piloting and expanding a mental health navigator position. And I'm currently working on a proposal to embed community health workers to help support our mobile unit in getting kids access to the care they need in those inner ring suburbs. And then last but not least, we facilitate healthcare education at every opportunity. So our APPs that staff our school-based health program provide our schools with maturation and puberty talks, dental hygiene education, and we participate routinely in back-to-school fairs and other community wellness events. We also act as a liaison to programs like Code Anna, which is a stock EpiPen program. So if a child who didn't have an identified food allergy or for whatever reason had a food allergy but didn't have their EpiPen on them, which we know happens a lot, the school has stock EpiPens that they can use if a child starts to show signs of anaphylactic shock that can save them. Similar programs put a lid on it with bike helmet distribution, things like that. And then the last thing I'll talk about here is workforce development, or our pipeline programs, we call them. So the target here is really opportunity youth, defined as young people between the ages of 16 and 24 who are disconnected from school and work. Several risk factors are known to contribute to that disconnection, such as low emotional self-regulation, parental incarceration, neighborhood violence. Other risk factors might include placement in child welfare, missing a number of days of school or dropping out of school, parental unemployment, experiencing discrimination at school or work. And this list sounds very familiar to the ACEs list that we talked about earlier. So you can see that there's definitely overlap in terms of the kids who might be most at risk and the ones who are disconnected from school or work when they graduate or leave high school for whatever reason. So one of our goals here is to strengthen those connections by engaging students in those high-risk communities early, giving them some career exposure and skills, linking them with talent recruitment to secure employment when they're ready for that. So this is an integral part of our higher local efforts that I talked about before. So just a few examples. Our high school internships include the science internship for those wanting experience in clinical work, the Lewis Stokes internship for those interested in non-clinical work such as quality improvement or research. The Discovery Accelerator internship is actually really cool. So it's offered to Cleveland Metropolitan School District students in 9th through 12th grade in partnership with IBM. It is a paid internship. Students earn $15 an hour, and it incorporates mentorships with Cleveland Clinic researchers on programs related to a quantum computer. In addition to that, professional skills training, including how to build a resume, how to interview, as well as wellness courses. So how do you take care of yourself? How do you budget? Things like that. Our Student Pathways program offers students who are nearing graduation, again, career coaching and mentorship in collaboration with talent acquisition. And it includes actually 3 different options. One is direct to employment, one is a certification program, and one is an associate degree option. So this model incorporates tiers of engagement, starting with career exposure in 9th grade, industry field trips in 10th grade, shadowing in 11th, and then work-based learning in 12th. The Pathway program is currently expanding in the city of Cleveland as well as Akron. And then when we think about other partnerships with stakeholders, thinking about Kent and Tri-C's community health worker programs, School of Phlebotomy and others, where we can kind of help support those students through their training. Once they get their certification or training completed, we can offer them a position. So I'm going to stop here and see what questions you might have for me. I know I threw out a lot, and I hope that this was helpful.
Let's sit here and have a conversation. Yesterday, I jokingly said that I would like to have Dr. Amy Edwards of, her, be my new primary care physician because her energy is up. Today, I think I want you as on the team as well. I have never heard a presentation within the space of 40 minutes that yielded so many story ideas. If I were a journalist, I would be all over this. Thank you. And the first question I guess I have to ask you is, when do you ever sleep?
I don't sleep very much.
I cannot imagine the energy and the mental energy that it takes to oversee and to strategize and to think about all of the things. But I think the most powerful slide you showed today was And it's something that, as somebody who's been in the business as long as I have, surely I knew this, but only 20% of a community's health is connected to clinical care.
Mm-hmm.
That is so powerful. And particularly when it comes to children. Because again, I think the perception of child health is, well, let's make sure they're nourished and let's make sure they don't break a leg and they don't get measles and they get vaccinated. So my first question to you is, well, first I wanted to ask you about Lakewood High School. You mentioned something about offering a tour. So what would we see if we did that tour?
Yeah, so actually when you go to the Lakewood in-school clinic, there is a door that when you enter, it's the principal's office on this side and a Cleveland Clinic office on the other side. And essentially you walk in, it looks just like any Cleveland Clinic primary care office. There's a front desk where you check in. There are 2 exam rooms. There's a mental health room. And then there's a conference room where our psychologists will do group therapies and things like that. We have everything that you would see in one of our offices. There's otoscopes on the walls, there's an exam table. And the idea is really that if a patient needs well care, they need vaccines, they need to be screened for depression, whatever it might be, but parents can't take off work to take their child to their doctor, we can offer that service right there. If they have a sore throat and we don't know if it's strep and they need to be sent home versus it's just a cold and maybe now we can say put on a mask and go back to class, being able to do that type of an assessment for them. If it's reproductive care and they want to be able to get their depot injections or birth control or whatever on site without having to miss school, we can offer that for them as well. So really it's a primary care office embedded in the school.
And how many of those do you operate?
So right now, Lakewood is our only in-school. We were in conversation with several others prior to the pandemic, and then funding freezes kind of put that on hold. But we're now resuming conversations with Garfield Heights, Warrensville Heights, again, some of those inner ring suburb districts.
And is this based on a national model, or are you guys the very first ones?
It's a national model,
okay.
Yes.
Are there any questions out here? Stop hogging the mic here. Let's start here.
Hi, my name is Anna Spurry. I'm a reporter at the Kansas City Star. Thank you for all of that wonderful information. Something I kept thinking about during your presentation is in Kansas City, we have a lot of these efforts in place, but they're just scattered through different organizations, institutions, nonprofits. There's not it's not all under one roof in the similar way that your program is. So as a journalist, one of my struggles is really measuring how effective and successful these different efforts are because they aren't all under one roof. And it's like you look at distribution of resources, they're all looking, many are trying to get money from similar funding sources. And so I struggle to figure out how to report on who needs more resources. Everyone needs more resources,
Yeah.
But also which of these are most effective, which need more help. I guess from your perspective, what would be a way to observe and measure that?
That is a great question, and this is actually where why we are joining the Food Insecurity Collaborative that I mentioned, run by Case Western, is because we faced the same thing when Mayor Bibbs and our CEO said, we want to address childhood hunger. How many kids are hungry? How much money will it take to feed them? Who's doing this work right now? What is their reach? We had no idea. And so really trying to pull those stakeholders together and collectively understand where are your needs? What have you been able to accomplish? And trying to pool all of that. It's not easy, but that has been the most effective that I've seen so far. And again, drawing on the expertise of partners like United Way, Better Health Partnerships, to do a lot of that data analysis for us. Because otherwise, I don't know what I would be looking at when I was trying to do that, but drawing in those people to do a lot of that legwork for us is helpful. I don't know if that answered your question. But... Okay.
Other questions?
Hi, thanks for this. My name is Jen Brooklyn. I report for the Detroit Free Press.
Mm-hmm.
And I don't know, just as a quick aside, in Flint, Michigan, which has also extremely high infant mortality rates, they're piloting a cash assistance program for expectant moms where over the course of their pregnancy and through the first year of the child's life, in I think maybe 3 different tranches, they're handing out $7,500 to each mom as pure cash assistance. And so it's like a program that is specifically targeted, you know, the hope for outcome is to improve maternal and infant outcomes, but it's a pure cash intervention.
That's phenomenal.
Fascinating. Yeah. And my question to you, I have the one easy one. You mentioned the 67% of the population has these ACEs. I'm assuming that if you broke that down, some communities, some cities probably have much higher, potentially much lower rates. Is that a fair statement? Okay.
Yeah.
Thank you. And then my question is also sort of about this funding piece. You know, so much of medicine is built on this compensation model based on insurance companies with their sort of black box price setting. How does something like this, can any of these interventions, including the one, you know, in Flint, can they ever scale unless we fundamentally overturn this basis on compensation?
Absolutely. So this is where the shift towards value-based reimbursement could be helpful. So if we're thinking, you know, especially Medicaid payers, for example, are very interested in lead poisoning. And so that's why, and I don't actually know if this is the case for other states, so I'd be interested to hear from you all if you know, but Ohio state law, the revised code actually states that children who are on Medicaid must have a lead test done at 1 and 2. And this is because Medicaid and the Ohio Department of Health joined together to pass that. So there is definitely investment from our Medicaid payers to make this happen. And part of the idea of value-based reimbursement then is if you, as a healthcare provider or a healthcare organization, successfully test 90% of your population that warrants it, we will give you this bonus. If you meet the basic requirement, we will reimburse you, you know, the full amount. If you aren't doing a good job, we have to think about ways to increase that, and whether that looks like less reimbursement or you know, thinking about resource allocation differently. So there is some change in thinking. It's just how do you implement that? Slow to come.
Any other questions? Oh.
Yeah. Hi, I'm Benny Alexander. I'm with Politico. I have 2 questions for you. One you sort of touched on is what's the cost to the patients and their families? Is there any was the insurance and where Medicaid involvement? And the second question is for reproductive care in particular, what kind of parental consent is required when you're administering those services?
Great questions. So in general, most of the programs that we offer, we will not bill a patient directly. We may bill insurance for some of them. So for example, I talked about our lead monitoring program and things like that. There's no cost associated with that. That's just something we are putting on our teams to do. School-based health, though, for example, we bill insurance just like we would in any other situation. Most of the patients who are enrolled in our program are on Medicaid, so they will never receive an out-of-pocket charge. But if they do have private insurance and they do receive a charge and they can't pay it or have questions about it, our financial counselors will help address that for them. So it depends on the program. Things like medically tailored meals and that type of thing, I believe right now we are doing free of cost to families. I can double check that though. But in the future, the idea is that those would also be billable services that insurance would cover and reimburse us for. That's the hope.
I tell you, the 2 things that probably sparked the most creativity in my brain were the Food as Medicine program and the Medical Legal Partnership. Because as we talk about this issue of the social determinants of health weaving through everything in our lives, if a parent can't afford to feed the children, their stress level rises, perhaps to depression. If they're fighting with bills that they can't pay and are being hounded, blood pressure rises, those sorts of things. Or people overeat because they're just trying to fill a hole. I'm absolutely fascinated by the potential impact. Have you been able to quantify what sort of impact these programs have had, or is it too soon?
We're working on that. It's a little bit too soon just now for our program, but if you look at more established programs at other healthcare organizations, they have demonstrated pretty significant outcomes. And I can find some of those for you if that would be helpful.
So when it comes to the food as medicine piece, for example, again, is that based on other programs across the country, or is the Cleveland Clinic piloting?
So that's actually a great question. I can ask that of Dr. Yepes Rios. I know that this has been a concept that has been discussed for quite some time. I believe that our program is one of the first in the nation, though.
Again, Bonnie, did you have a question?
Yes, actually, it's interesting that you bring up the food as medicine situation because we talked yesterday, and over the last couple of days, we've been presented with so many.
Introduce yourself.
Oh, I'm Bonnie Petrie with Texas Public Radio. So we've been presented with all these problems that impact child health and well-being, and not many solutions, right? And it feels like this is all the solutions that we were talking about at the bar last night. Like, what do you do? Wow, this is fantastic and really interesting. Another aside about lead, I feel like people think that that is an old problem from the 80s, and they think it's gone, and it's not.
Right.
I feel like everyone in this room should look at the lead situation in their community and do a story on it. That's another aside. Okay, question. The child and infant mortality numbers are a punch in the gut, right? Especially with regard to Black infant and maternal mortality. And you mentioned, which is something I know, but I don't know if it's well known, that when you put in education levels and socioeconomic levels, it's clear that these aren't the reasons. There are other reasons. Now, I've heard about implicit bias, and I've heard about lack of cultural competence. They seem pretty general and vague, though, and not very actionable unless you get more specific. So what are your thoughts on what is behind this this huge and terrible disparity?
Yeah. I do think it hinges on implicit bias and structural racism. So when you look at, there are actually some great stories out there of Black physician women who have experienced negative outcomes and their perception of their care and how they tried to advocate for themselves and were kind of shut down, versus a white woman who might have done the same thing and would have been listened to and cared for maybe differently.
I have to interrupt you. You remember the story of the doctor who filmed herself being mistreated in the hospital and she died. So it's
Yeah,
very real.
absolutely.
The concept is called weathering. In terms of the impact of racism and the stress related to it. I'm sorry, go ahead.
No, please. So I do think that, we have to look at it, and the difficulty here, of course, is that implicit bias isn't something that you can recognize in yourself and turn off. It is something that you recognize in yourself and then try to account for when you're having interactions with patients or clients or whatever. And so getting people to recognize that they have this, first of all, is a huge hurdle, because a lot of people are like, I'm not racist. This isn't an issue for me. I'm not racist. But they don't, if you actually do some of the tests and things like that, and you start to see where your biases might lay, even Black physicians have implicit biases against or for certain populations, right? So a lot of people will say, well, I'm from that community. That's not an issue for me. It can be. So really getting people to recognize it, and then what do you do with it, right? So how do you train people to think about that as they're going through their interactions with patients or clients throughout the day? And how does that result in behavior change? That's much more nebulous, and figuring out how to do that is very difficult. There are some concepts out there just in terms of trauma-informed care and things like that, kind of guiding you through how do you address a person from really any culture, or even culturally competent care. Some of those things can factor into mitigating implicit bias a little bit, but it's very difficult. Yeah, I don't have a great answer for you, but yeah.
We'll take a few more questions. Jennifer has.
Hi, thanks. So kind of a follow-up to that question, a little tangential to that, I'm sorry, but I'm so curious. I've seen a lot of literature about the kind of implicit bias and, worse health outcomes for people of color who come into a hospital setting, people who don't feel comfortable or feel mistreated in a hospital setting. I have not seen any of that literature as it pertains to kids. And I'm just curious, is there some, in terms of older kids or adolescents who come for medical treatment, is there anything to suggest that they have a similar experience? I would assume so, but I haven't seen that.
Yeah, it's a lot harder to get data on children in general because if you want to interview them directly, processes are much, much more difficult to get data from kids. So I don't know of any articles or studies specifically looking at this. I just know of general aggregated data showing outcomes. But that's something I think I could look into a little bit, and I can get back to you and share that if I find it.
Last call for questions. We'll take 2 more.
Hi, my name is Jackie Hendry. I work with South Dakota Public Broadcasting. I'm sorry if this is kind of a bit outside of your knowledge, but I'm thinking about with the medical legal partnership as it relates to tenants' rights and the lead issue. Because in my own experience, 20-year-old college kid renting an apartment, and then the day I'm signing my lease, my landlord is like, oh, and here's a paper to sign saying that you just like won't eat any paint chips because it's an old apartment and lead paint. And I'm just like, sure, okay. I'm thinking about that as it relates to Cleveland and such high rates and where that fits in for people who are renting in the housing market and limited options.
Yeah, it is. It's a huge problem because a lot of, so signing that paperwork now I think is not really an option. Homes have to be inspected in order to be rented out. What we do find, though, is that it is so difficult. The housing market here is so difficult. Even rental market is so difficult that families would rather, even though that they know that there's contamination in the home, it's too disruptive to their work, to school. They may or may not have transportation. So it's too disruptive to leave that home and go somewhere else than to just ignore it and try your best to clean as you can. It's very difficult to identify those homes and actually address the issue. And a lot of landlords will, prior to this Lead Safe Cleveland ordinance, if you didn't know that your house was lead contaminated, then you didn't have to disclose it, obviously. So a lot of renters would just opt not to do a home inspection before they rent because then they don't have to disclose anything. And so this was pretty well known. And so now that we have this lead safe ordinance, we're hoping that we'll see that change, but I don't really have outcomes yet to share. But yeah, that's the paperwork is interesting because kind of getting them out of any liability for it, right? Yeah.
Rania, the last question.
Reproductive care, absolutely. I realized as we moved on that I didn't answer that. So yeah,
Oh, okay.
It is. So it's very interesting because state by state, laws around confidentiality of reproductive care are very different. In Ohio, there is nothing very clear cut around what you can and can't do. So we just tend to do what we can for the patient in front of us. Typically what I will do, because, for example, birth control, I should be able to prescribe. If a patient wants to come in for depo shots or an implantable device or whatever, I can do that. If it's more, they're coming to me and they're pregnant, I worry for that child, right? How are you going to manage a pregnancy on your own? Let's have a conversation about who your trusted adult is. How do we want to have that conversation with them? I can help you with it. We can call them. We can bring them in for a second appointment, but let's figure out how we're going to do that. So definitely, there are pieces of that I can do confidentially with just that patient. STD screening and treatment, those types of things we can do. But if it gets to be to a point where I'm worried about the welfare of that child overall, then I will involve other people. But there's not clear-cut law in Ohio. And this has actually come up in school-based health quite a bit because schools, of course, want us to be able to say that we will provide 100% confidential care. They don't want anything going home to parents. And I can't always promise that if it is not in the best interest of the child. And then if it's okay, actually, you said something earlier that made me think of a story of a patient that I see. You were talking about social determinants of health and how the 20% stat was very powerful. And so just to kind of put this into perspective, I, of course, see many obese patients in my practice. And I was having a conversation with one, and I didn't even, it didn't dawn on me when I was asking the questions, but I was like, okay, so summer's coming up. Like what are some ways that you can stay active? What are some ways, what are you going to do outside? And they're like, we don't let our kids play outside. There's no safe place for them to play. So just that concept of, the space around them and how that affects their health, right? They don't want to go ride their bikes outside because they might get shot. Where is a safe place then for them to play? Where can I send that child? What are other ways to keep them active and healthy? And how do we ensure that safety piece as well? But just thinking about how I can tell them you need to go and be active, but that other 80% is far outweighing what my recommendation in that moment might be.
Absolutely. Rania.
Hi, I'm Rania Sutirtho with NBC News. I thought it was interesting when you mentioned that the number of children who are coming in to check in on their health has not yet bounced back to pre-pandemic levels. And I was wondering, what do you think is preventing these numbers from bouncing back? And you also mentioned that it'll be the responsibility of the hospital to reach out to these children. And how do you plan to identify these children, and how do you plan on reaching out?
Sure. So I think a lot of it has to do with the politicization, if that's a word. Did I make up that word?
No, that's
of the pandemic, of healthcare in general, and the idea that a lot of things are voluntary, right? So I don't want to bring my child in for a physical because I know you're going to want to give them vaccines, and I don't believe in vaccines. Or I don't believe in the COVID vaccine, and I don't trust that if I bring my child in that you won't just stick them with it anyways. So I think that in general, there's a devaluing of care. I think too, there's not a very clear understanding in the community about what well care is, right? So for a lot of people, if they take their kid to a mass sports physical and get check boxes ticked, that is the same as me screening for drugs and sex and depression and doing counseling and all that kind of stuff on healthy diet. So I think that there's a little bit, from the community's perspective, a little bit of a misunderstanding about what we're trying to offer, when really all that they want is their sports form signed. So is it easier to go there and spend $20 and get it signed, or coming in and having these kind of hard conversations with the pediatrician? So I think there's mistrust. I think there's also, earlier on in the pandemic, there was this sense of, well, you only go to the doctor if you really, really need to. Otherwise, that's a place where you could get sick, right? You could get COVID there, so don't come in unless you really need to. I think some of that thinking is still there a little bit, and so people come in when they're sick, but they're not coming in for their physicals. And then I think it's just general priorities, right? Like, people are more worried about where they're gonna get their next meal. They're more worried about keeping their job, where if they were to take off another time to take their child to the doctor, they may or may not still have that job. And so really focusing on, when do I need to take my kiddo versus they're due for their physical, let's just go in and get everything checked out. So I think there are multiple different pieces to that. The second part of your question was around how do we identify and reach out to those. Our electronic medical record system, and most of them out there now, have the ability to create what we call registries. So this is where a lot of our population health work comes from. Each of us, for a practice or for a provider, has a list of the patients that are attributed to us, and it will give us a report of who is overdue for what. And either I can send out bulk MyChart messages that say, you're due for this, please call us and come in. Or I can have a member of my team, if not myself, call each patient individually and talk about what they're due for. Let's get you scheduled. So our medical record system has actually built in the capability to do a lot of that work.
Thank you.
Yeah.
I have to thank you, one, for providing half the content for the third training that we're going to have already. I mean, I'll be bugging Jen and everybody about speakers for that. But more importantly, I think helping journalists like the ones in this room really expand their consciousness about this issue and the need to truly interpret it properly has been invaluable. So I'd like to take this opportunity to thank Dr. Roopa Thakur for joining us today.
Thank you so much.